Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCrae.
Tracy, a recent article in the journal Mayo Clinic Proceedings concluded that adults with eating disorders do not seek professional help as often as they should. And that was particularly true for adult men and ethnic and racial minorities.
The article was accompanied by an editorial written by Mayo Clinic psychologist and eating disorders expert, Dr. Leslie Sim. She joins us in studio. It's very nice to have you here.
Oh, thank you so much for having me.
Dr. Sim, nice to see you.
Nice to see you.
So let's start out by...
I just was going to say, I'm really surprised this is for adult men, that this is a big problem.
It actually is. About 10 million men suffer from eating disorders in the United States at any one time. So it's a big problem that they're not seeking help.
No, you know women go to the doctor and men don't.
No, I think just the stereotypical, if you said who is a patient with eating disorders, I think 10 out of 10 times people would say women, not men.
Absolutely. And I think that's the problem, is there's a lot of myths about eating disorders that I think deter men and ethnic minorities and a lot of people from seeking help who don't fit the stereotype.
And when you say eating disorders, most of us just think of anorexia nervosa, but there are several different types. Can you explain that to us?
Absolutely. So anorexia nervosa is actually the most rare of the eating disorders, but I think it's most well known. I think it gets the most media attention. People are very intrigued by anorexia. But actually, there's two other eating disorders, bulimia nervosa, which is really where individuals are trying to control their weight or shape, but they oftentimes have experiences where they lose control over their eating and they eat large amounts of food, what we describe as binge eating. And because they feel so terrible about that experience, they will oftentimes try to compensate for the calories they consume by doing things like vomiting or using laxatives or going to the gym for 6 hours or even not eating the next day.
And then there's a third?
And the third actually is binge eating disorder, which affects a large number of American adults, about 3%. And it is associated with binge eating episodes, so eating a large amount of food and feeling very distressed about it. This is not something that people feel good about. They feel very distressed, and it really affects their health and their well-being.
It makes sense then that this is so misunderstood if the least known or the least often occurring, the anorexia, is the most widely known one. Of course, you're setting everybody up for failure when it comes to eating disorders.
Absolutely. I mean, if you think that anorexia is an eating disorder and you don't know about others, then you think, well, I'm not bad. I don't weigh, I'm not emaciated. I'm overweight. And actually, a lot of overweight and obese individuals struggle with very serious and even life-threatening eating disorders.
Are these mental or physical disorders?
They're categorized as psychiatric or what we call mental disorders, but they have significant effects on physical health, probably more than any other psychiatric illness.
But it's so interesting because I think this was a statement from your editorial, and it surprised me because it said eating disorders have the highest rate of mortality and place some of the highest costs on the system of any psychiatric disorder. True?
Absolutely true. About 20% of individuals with anorexia will die. So thinking 1 out of 5 individuals will die from the illness. Some of them die from health complications and some of them die by suicide.
And malnutrition? Is that?
Malnutrition is one part of the mortality risk. But other as suicide is actually a high risk for people with anorexia because it really affects one's quality of life.
And what about the bulimia and the binge eating disorder?
They also have high risks for health complications and mortality as well. So with bulimia, it can relate to electrolyte imbalances as a reason for mortality. And with binge eating disorder, it are more of your longer-term risks for diabetes and cardiovascular health complications.
So I'm going to assume that what we started, that a significant number of men and racial minorities, they must be more likely to have binge eating or bulimia. Is that true?
Absolutely. So what we're finding is that with binge eating disorder in particular, there's a higher rate of men than the other two conditions, which are predominantly female, as well as a higher ethnic minority proportion.
If you identify these people, or if they do seek help, what's the normal treatment regimen? I mean, is it a curable problem?
It's
treatable?
absolutely treatable, and that's why it's so disheartening when we're seeing people not getting treatment or even identified as having a problem, because they're very treatable, particularly if you treat them early before a lot of the health complications set in and some of the mental health complications set in. So very treatable. We use cognitive behavior therapy, which is a type of talk therapy that involves different changing behaviors and thoughts around eating, weight, and shape. And some people will benefit from some kind of medication. Not everybody needs a medication, but some people will benefit from that as well as a combination treatment.
Nutritional counseling also part of this?
Nutritional counseling is sometimes part of a treatment package.
And is this normally outpatient treatment, or are some people bad enough that they need inpatient treatment?
So most of the time it's outpatient, but for some people who have more of the health complications or are failing outpatient treatment, then we will consider a more intensive treatment, which might be considered a partial hospital program, a day treatment program, going from 8 in the morning until 5 and getting treatment more intensively, or going inpatient and being hospitalized, or a longer-term residential treatment program.
Does this normally require lifelong counseling and follow-up, or is it a matter of weeks or months and then most people are pretty much better without continuing help?
Very good question. I think it depends on the eating disorder and how severe it is and how long it's been going. But for a lot of people, they can be treated in 4 months of cognitive behavior therapy. So it is very treatable. Sometimes it takes a bit longer. I think with anorexia, it can take up a year or longer.
So since all of us, well, not you, but the two of us were thinking incorrectly about eating disorders, what should family members look for when they're seeing their loved ones that might be struggling with something like binge eating?
Absolutely. So what we oftentimes see is people start to modify their food intake. They might be saying, well, I'm not very hungry in the morning, and then skip meals, and then eat in secret. For family members might find food missing. Oftentimes this is a very shameful experience for the person, so they don't want to disclose that they're struggling, which can also add to challenges seeking help. We will oftentimes see people being very isolated. We can see weight changes and other challenges.
Well, the article pointed out a real problem. A lot of people out there with eating disorder do not seek help. What can we do? How can we improve the situation?
I think better public health campaigns obviously will be helpful, but I do think the responsibility is on physicians to better identify these people. I mean, physicians are educators, and
primary care physicians.
Primary care physicians. I mean, people don't know that they have cancer. They don't come in saying, "Hey, I have cancer. I'd like treatment." They need their physician to identify the problem, and I think, unfortunately, healthcare providers were all very subject to some of these stereotypes as well, and so unfortunately, we do targeted screening where we're screening the people we think are at high risk, but we're not screening universally. So we're not, when you come into the clinic, you don't fill out a eating disorder questionnaire.
Yeah, you do a PHQ kind of thing to find out what your depression is. But there could be, because unlike cancer, there's no shame associated with cancer.
Yes.
If they come in, this is going to be something that they already, for some reason, feel like they have to hide.
Absolutely.
Because of the shame associated with it.
You're absolutely right. So having those tools where we're screening everyone, and we're not just thinking I'll screen, college-age girls or, skinny teenagers. I'm going to screen everyone no matter what their weight or size is, age.
All right. Mayo Clinic psychologist Dr. Leslie Sim. Eating disorders are more common than most of us realize, and unfortunately, not enough of those who suffer seek professional help, particularly men, not surprising, I guess, and ethnic and racial minorities. We've also learned that eating disorders have the highest rate of mortality of any psychiatric illness. Pretty incredible. It's apparent we need to do a better job of screening for eating disorders among adolescents and adults, everybody, right, Dr. Sim?
Absolutely.
Our thanks to Mayo Clinic psychologist Dr. Leslie Sim.
Thank you so much.